Hi, everyone. My name is Ronnie Elwee. I am at the VA Center for Healthcare Organization and Implementation Research at Bedford VA Healthcare System. I'm also a member of the Query and Office of Patient-Centered Care and Cultural Transformation funded program called CHEC, which is the Complementary and Integrative Health Evaluation Center. That is the group that sponsors these bi-monthly VA Complementary Integrative Health Cyber Seminars. So we're really happy to have you. Today, I'm really excited to introduce our speaker, Dr. Matt Bair. Dr. Bair is an associate professor of medicine at the Indiana University School of Medicine, and he's also a core investigator with the VA Health Services Research and Development Center, which is the Center for Health Information and Communication, otherwise known as CHIC or Chic. I'm not sure how best. I like Chic personally. He's also a staff physician at the Indianapolis VA Medical Center and a Regenstrief research scientist. Dr. Bair is a principal investigator. His research has been primarily on chronic pain and psychological comorbidity, and developing strategies to improve pain management in the primary care setting. He has a strong background in conducting clinical trials and developing and testing interventions that combine pharmacologic and non-pharmacologic treatments. His funded work in particular contrasts pharmacological and behavioral approaches to pain management. Over the last decade, he has led or participated with research teams and conducted 11 different randomized clinical effectiveness trials. 7 of those trials have been completed and 4 are ongoing. He also has a lot of different roles in terms of being on editorial boards for journals such as Pain Medicine and Journal of General Internal Medicine, and he served on several national VA committees related to improving pain management. We're really happy to have him here to speak specifically about massage therapy, which is something that we don't get to focus on very much in this cyber seminar series. And for those who are regular attendees, you will know that Allison Whitehead from the Office of Patient-Centered Care and Cultural Transformation joins us each session to provide insight and a commentary on the presentation just at the end of Dr. Bair's presentation. Allison is the director of the Integrative Health Coordinating Center and in Washington, D.C. as part of the Office of Patient-Centered Care and Cultural Transformation, and really leads policy and practice in this area. So Allison is a public health practitioner as well as a yoga therapist, and so we're always thrilled to have her insight and perspectives shared with us here today. So thank you, Dr. Bair. Thank you, Allison Whitehead. We're really excited to have you, and I'm going to turn it now over to Dr. Bair.
Thank you, Dr. Elwee. Thank you very much. That was an incredible introduction. Thank you. The only thing I would add, I'm a primary care doctor. I'm a general internist by training and have done research for 20 years in the primary care setting. So a lot of my comments and perspectives come from a primary care perspective. So I'm honored, thankful that you're all there, out there in the audience, and get to talk about our TOMCATT trial here. We've had some challenges, like all of us have during this time, but I want to talk about some of those challenges. I want to talk about some of our early findings. So the question is, why should we study neck pain? For us as a research team, we study things that are common, and neck pain is very common. In at least one study, the 12-month prevalence was between 30 to 50% patients with chronic neck pain. It's even more common in our veterans, and chronic neck pain is disabling. It's the 4th most common cause of disability in the United States. We also know that neck pain is associated with reduced function, impaired quality of life, and associated with psychological comorbidity such as depression and anxiety. We have several treatment options for chronic neck pain. Medications and physical therapy are the most commonly used treatments. And then relative to low back pain, chronic neck pain there's a relative lack of evidence of these treatments. Again, medications are commonly used, non-steroidals. We know that they're the most commonly used analgesics for neck pain. We also know that there's opiate therapy is used, and there's been a lot of discussion about the side effects of these medications and the controversy surrounding opiate therapy for chronic pain conditions. We know that physical therapy is used oftenly. It's very effective for some, but not for everyone. And so we need other treatments for patients. I know that I'm somewhat preaching to the choir with this quote from Dr. Josephine Briggs, former director of NCCIH. She said that the need for non-drug treatment options for pain is a significant and urgent public health imperative. Couldn't agree with her more. And so let's talk a little bit about the VA context for our study of TOMCATT. There's been guidelines and policies and to really try and reduce our reliance on pharmacologic treatment due to some of the controversies, some of the side effects, and needing other treatment options, knowing that patients don't always respond to medication management. The other context that's really important when we were designing this study was the Opioid Safety Initiative, initiated in 2012, where it's really focused on the goals of reducing high-dose opiate therapy, reducing concomitant opiate and benzodiazepine therapy, looking for and encouraging safer alternatives for treating chronic pain condition. And VA facilities were really encouraged and pushed to improve access to complementary and integrative health approaches. So we really need effective and safe treatments. We know that there is a very high demand for CIH approaches. At least in one study, almost a third of U.S. adults use these approaches. And pain is the main reason that our patients turn to CIH approaches. In terms of pain conditions, there are a lot of pain conditions. Low back pain is the most common reason that CIH is used. Neck pain is the second most common reason that CIH is used. In terms of specific modalities, chiropractic care is the most common, and massage is the second most common modality that is used. So let's talk a little bit about some of the evidence for massage in the context of neck pain. We know, based on some systematic reviews, Cochrane reviews, that massage is shown to reduce pain and or disability more than usual medical care, more than physical therapy, or no treatment. It has been found to be effective in the short term, but the long-term benefits are more unknown or more questionable. Unfortunately, in this systematic review, the overall quality of most massage trials was rated poorly. Small sample sizes, unclear on randomization, concealment allocation, what type of analysis approach, etc. Karen Sherman and colleagues in Seattle have been really set the standard for massage trials, and we relied heavily on her expertise and her team's expertise out in Seattle. Just want to highlight a few of Sherman's studies. First study, looking at a study of 64 participants, looking at massage for 10 weeks and showing that this 10-week program improved neck pain disability more than patients that were randomized to a pain self-care book. In a subsequent study of Karen Sherman team, larger study of 228 participants, it was a what called a dosing trial that looked at 60-minute massage sessions, either one time a week, twice a week, or 3 times a week. And that massage reached clinically meaningful improvements in neck pain disability more than control. And then lastly, there was a follow-up study that looked at the role of booster doses. So, and these booster doses, so those are booster doses beyond the 10 or 12 week treatment period, that these improved neck disability and pain at 12 weeks, but with non-significant changes at 26 weeks. So in terms of some of the biological plausibility, some of the theorized massage mechanisms, investigators have said that massage works by some of these mechanisms of increasing local blood circulation, improving muscle tone, especially if muscle tone is tense, tight. It can also increase joint flexibility. It can provide some benefit in terms of, indirectly through a relaxation response. And it can change neuroendocrine and neuroinflammatory biomarkers, which are implicated in pain generation and pain sensitivity in the central nervous system. There are some, real challenges to our patients and the public to accessing massage therapy. It can be costly. And at this time that we wrote the grant, the average cost was for about $60 an hour. And this can significantly vary by region. It can be more expensive on the coast relative to the Midwest, for example. The setting, whether it's in an urban setting versus more suburban or rural even, and cost changes based on the therapist and their degree of training. Typically massage therapy is a out-of-pocket expense, and for most of our veterans, this is really not affordable. I think this is improving. Massage therapy is, offered at some VAs. I'm not sure the extent of how extensive it is. It was only offered at a few VAs when we started this study. And we really have limited information about the cost effectiveness of massage therapy. So I want to switch a little bit to the concept of caregiver delivered massage. And as one idea, we had to potentially overcome some of these access barriers. And caregiver delivered massage had been tested previously, been generally done in a pediatric setting or on the OBGYN medical ward. It also been tested in long-term care settings for the treatment of dementia. Highly relevant to the TOMCATT study was a study by Layla Kozak and her colleagues that showed the feasibility of a caregiver-given massage in 27 caregiver veteran dyads. And in this study, this pilot study, it showed that this intervention decreased pain, decreased stress and anxiety, and reduced fatigue in veterans with cancer. In a slightly larger study of caregiver-delivered massage, Colinge and colleagues looked at 97 patient caregiver dyads, looking at a massage intervention versus attention control. And this study showed that it decreased pain, the intervention decreased pain, improved depression, and other cancer-related symptoms. Also interesting, I found in this study was that the caregivers, those that were delivering the massage, also benefited from doing hands-on massage. And at this time, there was no previous studies in veterans with chronic pain and the effect of caregiver-delivered massage. So again, building on, what was our rationale for this study? We study high prevalent conditions with significant disabilities such as chronic neck pain. Unfortunately, chronic neck pain has been largely neglected condition studied in veterans. We know chronic pain generally is associated with decreased satisfaction with VA care, and that less than a third of veterans report very good or excellent pain treatment effectiveness. So we have a lot of room to improve our pain treatments. We know that massage is highly preferred by veterans. They really want massage therapy. And this was also in the context of, the opioid safety initiative that VA facilities are being mandated to reduce reliance on opiates and increase access to complementary approaches. So our initial primary aim was to compare the effects of two massage interventions, caregiver-assisted massage and therapist-treated massage versus a weightless control on pain-related disability. We had two secondary aims listed here. The first, to compare the massage interventions versus control on secondary outcomes, including pain severity, health-related quality of life, depression, anxiety, and stress. And our other secondary aim was to examine implementation potential of both massage interventions, including facilitators and barriers, looking at issues of treatment, adherence, treatment satisfaction and adherence, and intervention costs. So this was our initial TOMCATT trial design. That veterans were randomized with chronic neck pain to one of three treatment arms or study arms, caregiver or care ally assisted massage therapist delivered massage and waitlist control. The setting for our study were 6 primary care clinics at the Rodebush VA Medical Center here in Indianapolis. We also recruited from our surrounding community-based outpatient clinics. Our initial recruitment goal was very ambitious of 468 veterans with chronic neck pain. In terms of eligibility, we wanted participants and veterans with chronic neck pain for 6 months or longer. They had a neck disability index score of 10 or greater, and the NDI, a score of 10 or greater, is considered moderately severe. They needed to have access to a working telephone. They also had to have a care ally or a caregiver that was 18 years or older. This was typically a spouse. It could be a partner, a family member, or friend who was willing to learn and provide massage therapy during the study period. In terms of exclusion criteria, I won't read all these to you, but just to look, we were excluding people with complex neck pain such as whiplash, those with significant medical complexity that would make it difficult and potentially a safety risk for doing, coming to the VA or doing massage, some sort of contraindication. So those were the main, not the main, these are all the exclusion criteria, excuse me. So briefly, a little summary of the study arms. So the Care Ally assisted massage or CAM arm, it started with a 3.5 to 4 hour group training workshop. And these workshops were held between 2 and 3 times a month, and we had a capacity up to 6 participant dyads or 12 people overall. This workshop was developed by 2 of my colleagues, Dr. Nikki Monk and Erica Evans. Both are massage therapists as well as researchers. So during this workshop, the participants, the dyads, were instructed on a 30-minute massage routine, and I'll talk a little bit more about this routine. And then we were recommending that after they have the training, that they deliver this 30-minute massage routine at home 3 times per week for 12 weeks. So here are some of the components of this workshop. There was, general instruction on massage, its rationale, how to, a communication approach, some of the safety issues involved, some issues about chronic neck pain specifically, and trigger points that may exacerbate neck pain. There was a demonstration of massage techniques and then supervised practice. There was specific self-care routine components that were discussed and individualized, specifically around individual trigger point care. And then the care allies would demonstrate the routine and practice during this workshop. And then there was, follow-up questions. There was, we gave them the study activity log, which I'll show you in a little bit. And then we kind of closed the session and wrapped it up. We also gave them a supplemental training DVD to really supplement this in-person workshop. And so they were given this DVD. This is just kind of a screenshot of the components of the DVD, which, you could look at the massage demonstration, talk more about the study if they wanted, and they could play just one part or all of it. This was sort of a timestamp of the actual 30-minute routine and what we asked them to do and all the components, the routines you see on the left-hand side here, the routine parts, how much time they would do it, and what the veteran would be doing and what the care ally would be doing over here on the right. This is just a screenshot of our, our supplemental DVD. So we asked them, to play this while they're actually delivering the routine at home, and it had a, timer on the bottom, so you try and keep aligned with the instructional video here. This is the weekly logs, which we ask participants to fill out. There's a couple reasons. One, to, it helped us assess their adherence and, how many times did they do it a week, how many times, and then a little assessment of fidelity, where we're looking at their, sort of their faithfulness to the routine which they were taught in terms of the, the items of the routine. So we handed those out, and then we collected this data each week. So the therapist treated massage, the TTM. So this was therapist applied massage. It was delivered by certified or licensed massage therapists from our community in Indianapolis. They delivered 2 massage sessions that were 1 hour in duration each week. And again, these were delivered we had a separate treatment room for our TOMCATT massage sessions, and these were delivered for 12 weeks. Briefly, our waitlist control, they had check-in calls at the 2 and 4 month time frame. They also underwent outcome assessments at baseline 1, 3, and 6 months. They were instructed to continue their usual medical care, and then at the end of their 6 months, they were offered massage sessions. Our primary outcome, we did outcome assessments, as I think I just mentioned, at baseline 1, 3, and 6 months. Our primary outcome was the Neck Disability Index, or the NDI total score. And we compared the NDI from each massage arm to the waitlist control. We looked at absolute as well as change scores at the 3 month, which was the immediate post-treatment time period. This is just a picture of what the Neck Disability Index kind of looked like. There's 10 items, and for each item, it starts as low or no severity to high severity. So it'd be scored for each item 0 to 5. So the score range will range anywhere from 0 to 50. Higher scores represent more severe neck disability. And a score of 15 is considered 10 to 15 is considered moderate. Here's some other items of the NDI that we, as part of not only our eligibility, but part of our primary outcome. We also had a variety of secondary outcomes. We looked at pain intensity from the BP, brief pain inventory. We looked at pain interference, health-related quality of life, depression, anxiety, PTSD symptoms, sleep issues, stress, and pain beliefs, specifically pain catastrophizing. So I just want to share some of our challenges. We had challenges right at the beginning, where you can see the blue line here is our goal recruitment, and our orange is what we actually achieved. So right from the get-go, we dug ourselves a hole a little bit, and that's always a challenge in a clinical trial. If you get off to a slow start, it's hard to catch up, and we got into a little bit of a hole. Hope this doesn't sound like whining, but we had some recruitment challenges with startup delays. We had some difficulties in hiring study personnel, especially some of our massage therapists, and we were also faced with a hiring freeze, which complicated matters a little bit. We had a great team. I'm so proud of our team. We had a lot of efforts to boost our recruitment. For example, we broadened our eligibility criteria by lowering our NDI score. We were approved to send out email blasts to veterans that were part of this email listserv and their families. We updated our study brochure to make it clearly that it was a massage study, as that would be attractive to potential participants. We focused our recruitment efforts on married veterans. We added a research assistant to recruit in the evenings. We added capacity to deliver Saturday massages and training workshops on the weekends. We did a variety of presentations in person to our community-based outpatient clinics and their providers. We handed out brochures to a variety of veteran service organizations in our area. We added as an incentive free massage for veteran participants in the CAM arm. And we even asked those that had finished the therapist treated massage veterans to see if they could volunteer to be a care ally, since that was a rate limiting step. Not everyone had a care ally, those that didn't have one. So that was one strategy we came up with. So this is a little bit of our pie chart looking at our recruitment. So at this time we had 239 enrolled. Most people that, refused, felt like they just weren't interested. They were just too busy. We also had a fair number that their NDI was too low. They had neck pain, but it didn't meet our criteria. So, as I mentioned, had a great team. They worked exceptionally hard. We had to send out, over 7,000 recruitment letters. Maybe 14-15% responded to that letter. We enrolled 338 after their response and showing that they're eligible and interested, and then we randomized them to one of the 3 study arms. I think I skipped a part here. Maybe not. Yeah. Oh, so our initial sample size, again, quite ambitious. We wanted 132 per arm. We assumed a 15% attrition rate, so that ramped up our total goal to 468. With that big number, we had 80% power to detect a moderate effect size or a 0.4 standard deviation in our change scores, which again, our change scores in the baseline neck disability index between our treatment groups. And then we set a type 1 error of 0.017 for the 3 comparisons. The consort statement is somewhat complicated, and so consort statement is looking at the consort flow diagram here. The reason I wanted to show these individually is when it might be a little simpler, and I don't want to go through all of it, but just pay attention to what's circled here. So we had enrolled 102 dyads in the Care Ally arm. We had some problems with 46 they enrolled, but they did not actually come to the workshop, that training workshop. So that was a significant issue, 46. So that was significant attrition. What were the issues in therapists treated? Well, we had attrition, but we also had this issue of, what to do during COVID. And we had 17 that were in the midst of massage therapy in our facility that were placed on pause due to COVID. I'm going to talk a little bit more about that. Waitlist control is here. We didn't have as much issues in terms of, finishing outcome assessments and attrition, but we still had some issues in our waitlist control arm as well. So attrition there were big problems. We had much higher attrition than we expected when we first designed the study. In the TTM, we had, almost 28% attrition at the 3-month follow-up. We had significant attrition in the Care Ally arm, and it was really, as I mentioned, 46 of the dyads did not come, they enrolled, but they did not come to the workshop, the training workshop. Smaller attrition, but still fairly significant at 20% attrition in the waitlist control. And this is at 3 months. So this data really made us ask the question, is Care Ally, at least in our hands, is Care Ally delivered massage feasible? And we made the tough decision, at least for us and in our sample, it was not feasible. So we proposed a major project modification, and we proposed that we actually drop the Care Ally arm. It just did not seem feasible. And so this would modify our study from a 3-arm to a 2-arm study. This modification was approved by our funder and our IRB and others. and it was approved. So we modified our sample size and our analysis plan, and our recruitment efforts were really, instead of focusing on 3 arms, we focused on 2 arms, which did improve our recruitment. That our recruitment efforts focused on 2 arms. We were actually achieving more than goal for a while, which was great. But we reached another challenge, is that we were approaching our massage therapists. We had 2 massage therapists on staff at that time, and we were approaching their capacity. We just didn't have enough massage slots. We had more participants than we could get them in. So we had that challenge. And then we, of course, we had in March 2020, the COVID challenge. So I want to talk a little bit about the COVID-19 impact for us. I know it's affected all of us here. At Indiana University, research was restricted to only those of essential nature, and this was done back in March 23rd, 2020. Then in June, there was some non-essential on-campus research that began to reopen. We were still not open at RVA at this time, but that was on our university. Our team, the TOMCATT team, we did continue our research activities that we could do virtually. So we did our outcome assessments. We had some qualitative interviews, and we did some chart review looking at healthcare utilization and medication use. And we felt that, TOMCATT study, the close contact, the intimacy between a massage therapist and patients really pose unique challenges. We certainly could not do a virtual delivered massage, or we weren't creative enough to think of one. So and this was also in the context at our VA Medical Center that all our clinical activities had pivoted almost entirely to telemedicine delivered care. This was in rehab, this was in primary care, this is surgery, all. So we felt we couldn't do any, we couldn't do in person as well. So, over time, we consulted our clinical leaders, especially in physical therapy, occupational therapy, and chiropractic care, thinking that our intervention in TOMCATT is most similar to those that are delivered in physical therapy, occupational therapy, and chiropractic. So that close physical contact between a therapist and a clinician. So we were always consulting those leaders. We consulted massage researchers across the U.S., like what are they doing about their research in this time. We reviewed guidelines from massage therapy organizations on what to do in this case. We just had multiple internal discussions about what to do. We had a lot of angst, especially among our massage therapists about there was fear that they didn't want to infect any participant, and there was some fear that in that close intimate contact, they could become infected. We also, we wanted to follow state and local metrics of COVID infectivity rates in Indianapolis area and our Marion County. We were often way above the CDC's recommendation for, we were over 5% infectivity rate most of the whole COVID year, all of 2020. So we even considered other study locations. Eventually our study staff became vaccinated, which reassured us a little bit. We decided that we're going to restart incrementally. We had some veteran employees that were actually participants, and all our veteran employees were vaccinated. So we thought that was the safest way to restart incrementally. And then our goal is to, finish up those already involved and finish up recruitment as next steps. So in the last sort of segment here, I just wanted we tried to make some, lemonade out of lemons. We had some significant attrition. So we did a secondary pilot analysis of the Care Ally arm versus a waitlist control before the project modification. And I wanted to share some data with you on that, what we found. Our sample characteristics, for a veteran group, they were relatively young at 55. 80% were men. I think it's significant here. I provided the employment because I think we didn't expect this many to be employed, which, their work life, their work obligations, I think was a real barrier for them to engage in some of our study activities. So I think that's significant and may have been a barrier to our engagement. Racial breakdown, we about 72 white, 24% black. The other thing is a marital status, which I think is an issue that, 61.5 were married. Again, we required a care ally, and most of the care allies were spouses. So that was another, I think, barrier to our recruitment and our attrition issues. So let's look at our primary outcome was called the Neck Disability Index, and we were looking at changes. So here we have the care ally arm, here we have waitlist control, we have baseline, similar disability at baseline. And then you see the care ally arm, which actually showed decrements in their disability. So that shows improvement. Whereas in the waitlist control, we actually have, flat or somewhat increase in their, so there's worsening of their neck disability. So this is looking at within the group changes. So within the group, what is the change within each group? So within the group, and we're looking at a change from baseline to 1 month. So a decrement of 1.1, a decrement of 3, a decrement of about 3.2 in the CAM arm, or care ally arm, and that, there's actually an increase in disability within the waitlist control arm. We also looked at, so that was with the last slide I showed was within group. This is between groups. So what is the difference between the change in the CAM arm versus the change in the waitlist control? And we see that there's a change, 1.34, 3.33, 4. So these are improvements. There's more improvement in neck disability index scores in the care ally arm, which is statistically significant in the care ally arm. We also looked at some other measures. So this is the brief pain inventory. Brief pain inventory is looking at either pain intensity or pain severity or pain interference. And so this is a 0 to 10 scale. 5 is basically a score, moderate pain level. And you see going from baseline to 6 months, there's a decrement in the pain severity in the care ally arm. And there's a not much of a change, slight change, if anything, in the waitlist control. And then we looked at between group differences over here. So there's more of a change in the, more of a reduction in pain intensity in the CAM arm versus waitlist control. So we had, like a lot of studies, we had limitations. We had more attrition than we expected, and it was sizable in the care ally arm. There's limitations when you conduct a randomized trial at a single medical center. There's issues of generalizability. Do our findings apply to non-veteran samples? We also experienced a significant pause in the intervention delivery due to COVID, and how that's raised really big challenges in how we analyze, moving forward. So despite those limitations, I think there's some significant conclusions. I think we started with a quite innovative design, looking at 2 types of deliveries of massage in an understudied chronic pain condition in veterans. We experienced some attrition, some recruitment challenges. I've certainly have great respect for dyadic researchers. We found that dyadic research is harder. It's quite difficult. It made us question the feasibility of caregiver delivered massage. Should we give up on it, or is it really a selection issue? And we just need to be more careful how we select who might be involved in a caregiver, that we want to incorporate patient preferences more. because there clearly seems that there's some signal that there might, even despite all that attrition, there does seem to be a treatment effect. So for the people that were engaged and used it, it seemed like it did help. I think any type of massage intervention like that, there was a unique impact of COVID. We could not easily pivot to a virtual delivery, where many studies have done that effectively. We were not really able to do that. So in our secondary analysis, we showed that CAN was more effective than waitlist control. As I alluded to, we have some real analytical challenges as we move forward due to the COVID delay, as we restart and finish up recruitment and enrollment. And, our risk mitigation plan has been approved, and we're, hopefully off and running. I want to just thank the audience here. I want to thank our funder from the VA HSR&D. I alluded to my great TOMCATT study team that you see here. It's truly a team effort, and we had our challenges, and we needed a lot of brain power to figure out how to overcome these. And my email, my university email is there, as well as my VA email. If we don't have time to get to questions before the end of the hour, but I'm happy to answer questions. And I think Allison Whitehead might have some comments or questions, and I'll let her have the floor.
Great, thank you so much, Dr. Bair. That was a fantastic presentation and so exciting to hear about, and can totally relate to the COVID pivots and the pauses and everything there. So I'm glad to hear that you're able to slowly kind of start back up. So yeah, what you were presenting on really just spoke to me a bit around this whole concept and idea of whole health as well. You're talking about working with caregivers and allies to help with some of the sort of self-massage, and it just really made me think about our efforts to empower and equip veterans and their families, to help take charge of their health and life. So as you mentioned, there are a lot of different complementary and integrative health approaches that we're using now as sort of adjunctive therapies for pain management. So of course, including massage therapy. I know you mentioned chiropractic care. Also, we're seeing a lot of use of, acupuncture, battlefield acupuncture, and others for pain. We also have within VA a whole health for pain and suffering course that people might be interested in checking out. Also a non-pharmacologic approaches to clinical conditions table that we've put together in our office that could be a great resource. And just to briefly note, I know when you had started getting your study together, that was probably pre some of the work that we've been doing nationally related to massage therapy. We've been hiring some more massage therapists in VA to try to help, address that issue that you mentioned of access. And we've seen that grow a bit since the massage therapist qualification standard was published in 2019. And just a couple other things to mention. Dr. Sharon Weinstein, who I believe is on the call as a participant today, she's our national SME for massage therapy and is a wonderful resource. She does a lot of work in pain management for facilities or people on the call who might be interested in more of that sort of implementation side. And then also just a real quick sneak peek teaser, she and our lead for acupuncture, Dr. Julie Olson, have been working on an acupressure skills training that will be coming available hopefully later in the fiscal year. I'm not going to make any promises on that, but I know that they've been doing a lot of work. So hopefully we'll get some more folks, more staff within VA trained in acupressure, which we see as falling under massage therapy as a massage therapy technique. But I'll hand it back over. I think Ronnie, you'll be handling Q&A. I would love to just give time for, I'm sure there's some great questions that will be coming in for Matthew. So I'll hand it back over to you, Ronnie.
Thank you, Allison, and thanks, Matt, so much for a terrific presentation. We have a number of questions. First, I'm just going to ask a clarifying question. I think the answer is yes, but I just want to clarify. Were the licensed massage therapists in your study, were they VA employees or were they outside of VA?
Great question. Thank you I'd like to clarify. Initially, when we first started, they were non-VA employees. We've had about 4 or 5 different massage therapists. 2 have been really kind of the workhorses for us. One has become a VA employee. The other is still outside the VA.
Okay, great. Thank you. So we have some questions. One person asks, I think you mentioned this towards the end of your presentation, that the intervention was beneficial to the caregiver, perhaps the care ally. Can you elaborate on that?
Yeah, I alluded to that in the pilot study. Not, excuse me, it wasn't a pilot study. It's Colinge. So they had found that there was beneficial effects to the caregivers. Based on that, and I don't know all the specifics, but there was sort of a increased well-being among caregivers, that they felt like they were, they were relieved of some of their, depression symptoms, anxiety symptoms by just simply delivering this intervention. That was in the Colinge study. We did do care ally outcomes as well. I didn't present that data, and we haven't analyzed that data, but we appreciated that that it actually might benefit the care ally as well. So that's why we collected care ally outcomes.
Great, thanks, Matt. One person asks, what was the minimally clinically significant difference for the NDI measure?
Yeah, really good question. It's viewed as a sort of clinically significant difference would be a 5-point difference, a 5-point change. So the astute observer there notes that we didn't quite meet that benchmark in it was about a 4-point decrement or difference in the study arms. So it didn't quite meet that 5-point. You could argue it met clinical or statistical significance, but not clinical significance.
Okay, thanks. And I do know that sometimes those are different. One person asks, could the care ally be workable virtually? I know that you mentioned you were trying to figure that out. And I don't know if you've had any more thoughts about that.
Well, I think we have had thoughts about that, and I appreciate that question. We don't want to give up on the care ally arm. We think it does still have potential. We did face some challenges. We learned, and I think one of the things we learned is it upfront sort of who should, in our study design, we incorporate some degree of preferences that might help. We really target those, that are married. But we also think that during the course of a study, that a virtual sort of support from potentially a massage therapist, for example, where, we provided some support, like these check-in calls, but I just don't think that was enough. And if we provided some virtual support from, massage therapists, like saying, hey, you're doing well, that your technique looks great, keep it up, I think as we move forward, that might be something to incorporate in a design where, those that are in care ally arm, they need more support. I think we have to acknowledge that the care ally arm was much more intensive in terms of, investment of time. There's some degree of argument about, sort of a active versus passive intervention. And whether, a veteran that comes to a massage therapy session at the VA is sort of a passive recipient of a very helpful treatment, but there's some critics of that a passive intervention is potentially less effective than an active intervention where, activating and moving and those sorts of things. So that I think that issue is debatable. I think the involvement of the care ally was much more intensive. It requires a much more investment of time and effort, and we have to acknowledge that and potentially give those folks more support than we did in TOMCATT. Short
And
question, long answer. Sorry about that.
no, it's a great answer. And I'm just going to say there's a lot of comments in the chat. And so one of the comments is from Dr. Weinstein, who Allison mentioned was on the call, and says, for advocating for a hands-on technique. And that's really required, and that maybe intermittent coaching virtually might help. So maybe there's sort of a hybrid approach. It sounds like.
Absolutely. I'm all for hybrid approaches. I think support is really critical as if we think that, and I do have I believe in this intervention. I think not in the way we initially designed it. And we learned through our mistakes, I think, and moving forward, I think that approach, a hybrid approach, hands-on with some care ally sort of virtual support, I think that's an excellent idea.
And there's some further quick clarifying questions, Matt, about just the massage therapists in general. And I don't know if this applies if it's because it's a state-related question, but somebody asks, what is the massage therapy standard in Indiana? And maybe that's also a question for Allison. I don't know if it's a national standard that we have, or is it, is this relevant to Indiana specifically?
Well, I'm sorry. I might have to defer. Allison might be able to. My limited understanding, I think there are different state standards in terms of licensing versus certification, and so I think it is somewhat state by state. What are the requirements? Nikki Monk, who's a licensed massage therapist, is different than Erica Evans on our team, who is a certified massage therapist, and there's slight degrees of training differences in what state that they initially got licensed. So there's not requirements in Indiana for licensure, but there is requirements for this certification. And I don't understand, I can't articulate the specifics of that. And if someone wants to email me that and they're really interested in that, I could look at it, but I don't know off the top of my head.
Yeah, no, I think you did a great job. This is Allison. So, and I know, and Sharon was also typing in, and I was going to say you're right, there are different requirements for massage therapists by jurisdiction. And what I had been mentioning in my comments was that, VA has set qualification standards nationally that is available on our IHCC SharePoint site. So Ronnie and Maria, perhaps I can get that link to you in case that's something that could be sent out to folks. So hopefully that is helpful in answering the question. But yeah, thank you, Matthew.
You're welcome.
Yeah, I think that would be great. And then that might also help answer some questions. There's another question, asking if the therapist were a medical massage therapist. So maybe that's even a different qualification. I don't know if either one of you know anything about medical massage therapists.
I don't. I'll defer to Dr. Weinstein or Dr. Whitehead about that. So.
Yeah, and Sharon's putting in the chat here too, or in the Q&A, not the chat, that there's no qualification for a medical massage therapist. But yeah, if folks do have more questions on some of those sort of the implementation, policy, guidance kinds of questions, Sharon and I are more than happy, to chat with people. My email is Allison, ALISON.Whitehead, WHITEHEAD at va.gov. And then, Sharon Weinstein, also, we, again, are happy to answer any of those kinds of questions, because sometimes it might be specific to your site, your location, but we're always happy to do that. And I'm volunteering Sharon since she can't speak up.
And she can't speak up, but she's been a great participant in chat. And I was just going to say, Dr. Weinstein, there's a message earlier on that you in the chat, or in the Q&A, that you might be able to answer. Because it's about if a natural health therapist that's been trained in massage but is not a massage therapist, I'm wondering if this person would be eligible for the acupressure training that you might be doing. So maybe you can respond to that question in the chat too. That would be really helpful. Thank you. Matt, I actually had some of my own questions that I wanted to ask you. And my first one is that I really love the rigor of how you developed the different intervention components, that you really worked with. You said, Dr. Monk and others, but do you have any sense of whether these components could actually be accomplished during like a routine therapeutic massage session at a VA hospital? I mean, and not necessarily the care ally one when you need a partner, but are these things, one of the things that we always worry about in implementation is, are we doing things that can actually be put into real practice? And so I just wondered what your thoughts were on that.
No, that's a great question, Ronnie. I mean, I think we always have to look towards implementation and feasibility in our healthcare system. I think if you're looking at some of the Karen Sherman studies, especially the dosing studies, where in that study looking at once a week massage versus twice a week versus 3 times a week, 3 times a week was actually had the greatest treatment effect. I would say that we sort of fell on twice a week because we were concerned about that very issue of feasibility and implementation potential, that an intervention where a veteran has to come into a VA medical center 3 times a week, I worry potentially, we have trouble getting our patients coming in the primary care 3 times, every 3 months. So 3 times a week has some challenges, I think. And so that was one of our deciding points of why going with twice a week. Twice a week would be easier than 3 times a week. Otherwise, I think it is feasible. It is potentially implementable in the VA. What we were, I don't think anything we were proposing, the duration is not you can't do. We had space set aside for our massage room, so that might be a challenge at certain VAs where space is highly limited. But we didn't take up a lot of space. We had 1 exam room essentially. It was a fairly large treatment room. It wasn't your typical your typical exam room. It was a little larger. So I guess the short answer is I think it is. I think it is implementable.
Yeah, that's great. And I know that you study implementation science, so I'm talking to an expert about that as well. So thank you. There's another question in the chat about, could you potentially consider having a massage therapist go to a patient's home? Is that a potentially feasible intervention?
I'm really intrigued by that, any sort of home delivered intervention. And we actually considered that during COVID, actually. I guess we didn't pursue it in earnest just because we had some concerns about safety concerns. And would that be approved? What would the approval be? And sort of some challenges on approvals and safety issues. But I'm intrigued by, home delivery, as Allison mentioned, any sort of self massage or self delivered interventions, peer delivered interventions, anything that we can sort of expand access to some of these helpful treatments, I think we should do. And sort of that, maybe it's a cliche, is sort of meeting people where they are. Going to the home is really meeting them where they are. So I'm intrigued by that. I think we had some concerns about overcoming some of the regulatory issues and privacy and safety issues.
Yeah, no, I very much appreciate that. And I just want to say for people, if you're not following along with the Q&A, there's some really great comments in there, and someone just put a link to a separate training for medical massage therapists in there that happens, it looks like, at Mayo. So if you'd like to look at that, that's there. I know that we only have 1 minute left, so I'm going to stop because I know Maria would like to close with some comments. But before she does that, I just wanted to say we do this bi-monthly, so our next session is in May. It's May 20th. You'll get a notification about that, and hope you can attend. Dr. Diana Burgess from VA Minneapolis will be here talking about some mindfulness work that she's doing. So look forward to seeing you in May. And Maria, please close the session for us. And thank you to everyone.